I'd like to talk just a little bit about posture because it's such a hot topic in general and then with orthopedic disorders as well. And I'm embarrassed to admit I used to be a little bit more dogmatic about posture, and now I am more respectful of its impact on the individual in front of me. However, that being said, I do think there is a strong correlation between the position people's bodies are in, i.e., their posture, and their incidence of orthopedic complaints. And there are numerous studies on this, and I will admit I have not read all of them. But I think a missing piece of the puzzle is that so many of these studies look at the position of the spine with a person's posture and the incidence of a person's spinal complaints. And I think that's missing a contributing factor, which is the spine contributing to extremity complaints. So I'll speak from personal experience. I've had a couple lumbar disc herniations, and posture matters for me. I don't have to be extremely diligent and never go into a slouched or forward or rounded low back position. But if like recently I bought a new bar stool and I was just sitting on it for hours and I wasn't really paying attention to my posture just because it didn't seem to be having an impact, but over the weeks it did. And so if it's relevant, it's relevant. And how did I know it's relevant? Well, for one, my low back started hurting a little bit on the right side. And secondly, I could notice a loss of motion. And as I've said many, many times before, it's so important for me to teach patients how to determine if they're losing motion because that is almost always a precursor to pain if they don't come on at the same time. So having noticed that I sit less time on the bar stool, or when I do, I make sure I'm very upright. And secondly, I'll spend more time on other surfaces. But if it weren't relevant to pain or loss of motion, I wouldn't really care about it for me being such a stickler. But since it is a problem for me, if I do it hours a day repeatedly, I'm more aware. And it's not a big deal. It's just creating a new habit. So when I assess a patient, I'm really looking at one person, an N of one, and in my evaluation, I adjust the person's posture to see if there is a change in symptoms for better or for worse. Now, that could be hand pain. I adjust their upper back and neck posture. It could be knee pain or low back pain, and I adjust the person's low back posture. I try to use the word adjust versus correct because we don't want to assign value to posture. There are people with orthopedic complaints who do better when their spine is in a C-curve, flexed, slouched posture. Admittedly, those cases are rare, but they exist. So of course, sometimes I'll slip and say correct your posture, but it's more proper to say adjust one's posture or change one's posture, because what I'm looking for when I quickly assess is if there is change or not. So if you have right knee pain and we change your sitting posture, and that right knee pain was there when you were seated in a certain posture and it's not when we change it, that's a very important piece of information. And that's something that for now is relevant to change at home or in the office because there seems to be a correlation. It has to bear out over time, but that's what the examination is, determining things that we need to test for longer periods of time. So it can come to spinal pain, it can come to extremity pain, numbness, tingling. If it's present or if it's not present, I will change the person's sitting posture and see what happens. Centralization of symptoms is a great sign. Peripheralization of symptoms is a poor sign, indicating that that change of posture is not something we want. And obviously, if it diminishes pain or increases pain, those are pieces of data that will inform where we go with the home program. It also informs what I think the person is likely going to respond to in terms of movement, because if I go from a slouched posture to an extended posture, and it's a beneficial response, then I'm starting to think, okay, there's a good chance that extending the spine is going to be fruitful for this patient. Or if their hands are numb and tingly and you put their neck into retraction and their hands start to feel worse, more tingly, then we have a sign maybe not to go into retraction and maybe try protrusion or flexion or something that's not exactly that motion. But that information will be borne out when we do the full physical exam. The evaluation of posture is the beginning part of that exam. I will say that in the general population, my advice is vary your posture. And I would say the best advice is also don't slouch for 7 hours a day. However, if you can prove to me that you can slouch 7 hours a day in a rounded low back position and mid back and neck protrusion, and you have no orthopedic complaints and you do not lose motion in the opposite direction, then I don't have a leg to stand on. Then I can't prove to you there's any deleterious effects from being in that posture. But in my mind, it's more likely that you have some down the road if that's what you do. So I tell a lot of patients, especially who are extension responders of the spine, a great way to break up the day not only is standing, but lying on your stomach propped on elbows. That's how I do a large amount of things, typing, emailing, being on my phone. It just breaks up postures of sitting, which even when you're sitting erect, the lowest part, L5-S1, is going to be flexed, I believe, 60%. So I remember telling someone this, that look, I can't prove to you, these are just what I've seen in 10 years. This is what my intuition tells me from everything that I've studied about the spine for a decade. And I said, I've seen my dad slouch my entire life. He's never complained of any back pain. And then I told my dad that I had referenced him in that manner. And he said, oh no, I have back pain. So I told him, of course, we could probably fix this with some simple movements in the opposite direction. And he wanted nothing to do with it. So I just let it go. But again, let's just not think of posture's importance on the spine. Let's also think of posture's importance on the extremities. And though we focus on seated posture, because that's what most of Westerners tend to do for up to 15, 16 hours a day, there's also standing posture, there's also sleeping posture, and we talk a lot about how the spine is positioned, but of course, if you lie on the couch on your elbow, then the posture of your elbow might be relevant to your symptoms. If you sleep and one hip is fully flexed on your side, then that sleeping position, that posture of your hip might be relevant to hip symptoms. So these are just a few things I think about when I think of posture. I absolutely evaluate to see if it's relevant to a patient's complaints and if changing it is going to help get the patient better faster. And if it is and we find it to be relevant, then we go over how to change things in his or her daily life to make it easier to change the habit of posture, because posture does become a habit, but there's easy things to make your sitting surfaces, for example, conducive to postures that won't create symptoms. And once you have the setup, now it's just a matter of taking some time to create a new habit that will become your long-term habit.